And we would like to invite our next speaker, Dr. Mahesh Goel. He will be speaking on the reality and the myth of neoadjuvant therapy for carcinoma gallbladder.
Thank you for having me. I was hoping that Supriya will advocate strongly surgery for locally advanced gallbladder cancer so that it would make my job of advocating neoadjuvant chemotherapy much more easier and simpler. So anyway, starting on my talk, surgery still remains the treatment of choice for gallbladder cancer, but as of now, I would say definitely for early stage. The treatment challenges that we face is in treating gallbladder cancer is that most of the gallbladder cancer occurs in low resource endemic areas like Chile, India, and on the east rather than in Europe or America. There's vast amount of difference in staging, treatment and survival with till now no level 1 evidence, and most of the current guidelines which we have represent just individual institutional based practices. And what is more striking is that most of the treatment is clubbed with cholangiocarcinomas. So there is no individual study on gallbladder cancer or guidelines per se for gallbladder cancer. And there is no high quality data for chemotherapy or chemoradiation in perioperative neoadjuvant or adjuvant setting till date. So if we really look at how gallbladder management has evolved from first surgery in 1780 to surgical nihilism as advocated by Blalock in 24, we have come a long way as far as surgery is concerned to the present surgery, which is a modification of modified Glenn now. But if we really look at outcomes where the surgery has taken us, these are two large studies from Japan and Korea, where cancer registries where they have shown that for stage 3 disease and node positive disease, the survival outcome rarely exceeds 40%. So why is it so that the survival outcome is not improved with surgery or radical surgery in gallbladder cancer? That MSKCs published their paper in 2003 where they compared gallbladder and cholangiocarcinoma and showed that the gallbladder is a much more aggressive cancer and the distant failure rates in gallbladder cancer are very high, up to 85%. We published our own study and showed that even after curative resection, 30% of patient recurred, that is for all gallbladder cancers, and almost 75% failed distally. So, and this failure was seen in gallbladder cancer with advancing stage. So this obviously brought us to the fact that surgery can do only this much beyond a certain point as the stage advances. If we have to improve survival in gallbladder cancer, something more has to be added to surgery, and that got us thinking about perioperative management in gallbladder cancer by looking at both adjuvant and neoadjuvant chemotherapy. So we divided gallbladder cancer into 4 groups. So this is how we actually treat gallbladder in Tata Hospital. So early gallbladder cancer, which would probably be stage 1 and few stage 2, early stage 2 T3 type of lesions, where the survival outcomes is upwards of 80%, surgery is definitely the choice. Metastatic we are not considering only because whatever you do, I mean, there is no 3-year survival also for metastatic gallbladder cancer. So two places where probably chemotherapy or any other intervention other than surgery can benefit patients or make a difference was incidental gallbladder cancer and what we then defined patients as locally advanced gallbladder cancer. So if you really look at these pictures, large liver infiltration, periportal node causing a type 1 block with obstructive jaundice, right hepatic artery involvement with the type 1 block, or for that matter even a duodenal involvement and involvement of the colon. So I know there are surgeons here, especially Dr. Shivendra also, who would advocate aggressive surgery for almost all of these. But will it really benefit? So we started looking at what would be comprised as a high-risk gallbladder cancer, especially for patients who were either T3 and above or node positive disease, where mainly because of high risk of micrometastatic spread with early lymphatic and hematogenous spread. So we kind of started looking at those gallbladder cancers as high-risk gallbladder cancers, which identifies patient at high risk of failure post-surgery, and introduce the concept of perioperative therapy, where we would like to test chemotherapy early before operating. The possible clinical benefit of this approach was it would naturally select tumors with less aggressive behavior, increases R0 resection rate, which will definitely reflect in increasing the overall survival, and downsizing of the tumor. I am not saying downstaging of the tumor, but downsizing of the tumor to improve resectability. So first paper we published, we looked at neoadjuvant. It's a pilot study we started in 2011, I think. We looked at, gave chemotherapy 37%, and you can see the amount of response in liver. And we were able to resect almost 46% of the patients, which would have been otherwise unresectable, with a significant overall survival benefit. At the same time, even in Delhi, they were looking at neoadjuvant chemotherapy. They published the same paper, almost a similar paper, showing that neoadjuvant chemotherapy improves resectability in unresectable gallbladder cancer. We also looked at chemoradiation during the same period, another pilot study from my group only, where we gave chemoradiation to patients and then operated. We could operate almost 50% of the patient, and 50% of patient we could operate with the overall survival, which was almost double of what would have been achieved otherwise. Only problem in this study was that the our bile leak rate were very high, almost 46%. So that led us to modify our radiation protocol. This was in early 2010, 11, 12. So now I'll come to the new study which we are doing right now. So, and then we published our first large paper on multimodal treatment for gallbladder cancer, where we showed that the systemic nature of gallbladder cancer becomes more evident with advancing age. Nodal positivity and stage are the main factors affecting long-term survival. So if we can select patient carefully and give perioperative chemotherapy and surgery, we can achieve much better survival outcome. So, and we could show that even for stage 3 disease, the survival improves up to 60% in these group of patients with multimodal treatment approach. But we needed to define. I mean, we gave chemotherapy, we gave radiation to patients which we thought were locally advanced. So the next important step was to define what is locally advanced gallbladder cancer. So these are the very important paper which we published, where we defined the criteria which can be used for selecting patients which were locally advanced, non-metastatic, or what we term them as borderline resectable gallbladder cancer. And with this paper, we introduced the concept of high-risk gallbladder cancer to the world. So we classified the tumors based on almost like at that time BRPC classification, T stage, T3, T4 tumor, node positive patients. Radiologically, there are radiological criteria which can tell you that node is positive or not, and vascular involvement. But fourth group which I introduced in this was incidental gallbladder cancer. My thought process was that if a patient presents to you after index surgery and shows disease either in gallbladder fossa or node, so either the disease has come back too early or the surgeon has cut through the tumor for the disease to come back so early. So those are patients which are still a high risk of local recurrence or distal metastasis. So those are also part of locally advanced or borderline resectable gallbladder cancer. And we showed that patient who could undergo curative surgery in this group of patients after neoadjuvant chemotherapy had a statistically superior overall survival, 49 months versus 7 months. And that chemotherapy with neoadjuvant intent in these selected, defined locally advanced or borderline resectable gallbladder cancer showed good response. Of course, now the time has come for us to prospectively validate this concept of high-risk gallbladder cancer. Same time, MSKC also published their result of neoadjuvant chemotherapy and said that definite resections are possible in a subset of patients selected for surgery after a favorable response to chemotherapy and was associated with long-term survival. Another group was obstructive jaundice, which always makes it locally advanced. This is our study, the largest study published on obstructive jaundice, where we showed that patients of obstructive jaundice who were offered curative resection after neoadjuvant chemotherapy showed response rate of almost 45%, and that patient which had direct bile duct infiltration definitely fared better than patients, of course, who had a nodal compression causing obstructive jaundice. But then Krish Menon published a systematic review in EJSO 2018 for, if you can see, barring 2 studies, all are from India, 3 are from my center only, where he concluded that there is insufficient data to support the routine use of neoadjuvant chemo or NACTRT in advanced gallbladder cancer. But he also mentioned that it benefited a third of whole cohort who eventually achieved a R0 resection. I take it more positively that patients who could be downsized to achieve a R0 resection definitely benefited. So there is a way forward for these group of patients for improving overall survival. And this is our prospective. Now we had to generate a level 1 evidence. Till now there is no level 1 evidence in gallbladder cancer. This is our prospective study which would hopefully give us a answer about whether neoadjuvant chemotherapy works or neoadjuvant chemoradiation works. It's Polka GB trial for locally advanced gallbladder cancer. We have accrued almost 125 patients, but still a long way to go. So finally, even if you now look at NCCN guidelines, this is 2022 gallbladder cancer, you can see neoadjuvant chemotherapy has come up for incidental gallbladder cancer in NCCN guidelines, as well as patients with jaundice, so which would which is a surrogate marker for locally advanced gallbladder cancer. So finally, I would say that gallbladder cancer is actually following, if you really look at historically the evolution of surgery, evolution of management for any solid organ tumor, we always start with surgery, then a very radical surgery in the hope of eradicating all cancers in the patient. Patient also feel good, surgeon feels, of course, surgeon feel very good that has done a brilliant surgery, and but the outcomes may not be same. So everywhere for all solid organ, it's always been surgery. Then adjuvant therapy comes in when people realize they have to increase survival, and once adjuvant shows benefit, then people start thinking of adding new adjuvant to test tumor biology and improving downsizing, improving resectability and overall survival. And that is how management has gone along for all solid organ tumors. So yes, surgical resection is still the current standard of care, but we have to realize in gallbladder cancer the failure is not local. So more radical surgery is not going to improve your survival. 75% failures occur distally, liver, nodal or other visceral metastasis. Adjuvant chemotherapy has now been standardized and is a part of gallbladder cancer. Any T2 above and node positive disease has to receive chemotherapy. There is definite emerging role for neoadjuvant chemo and probably chemoradiation, but as of now we don't have any level 1 evidence or even level 2 evidence for that. We are moving further ahead with molecular targets and precision medicine which are going to come, but definitely it is a time to look beyond surgery. Thank you for your kind.
Thank you, Dr. Mahesh, for a nice talk. The talk is open for questions. Before that, just a small thing. Congratulations for getting the incidental gallbladder into the high-risk group, because I believe that's a very large section of patients in the Indian subcontinent, and people never knew what to do about it, and they actually require the most intensification of the treatment. Yes. Because that's what is more important, because so that's a large section.
Yeah, I have not put in this, but we have published our paper on incidental gallbladder cancer, which is the largest series actually published, where we have defined how the timelines, and we have actually shown that doing surgery is more of a staging procedure than actually to define which patient will should receive chemotherapy.
And I think that's one of the best way to salvage these patients, because India being such a large country with varied practice, there will be so many gallbladders who will be opened up, or a laparoscopic cholecystectomy done and an incidental gallbladder coming out. My one small question is, what is your protocol of neoadjuvant chemotherapy? How many cycles? How do you assess the best response, and when do you operate?
So a lot of studies are going on now with even S1 coming into India now. Things are changing because S1 is less toxic compared to even capecitabine. But our protocol is, in Tata we did an adjuvant study and showed that not capecitabine, gemcitabine and cisplatin works very well. So our protocol as of now is giving 3 to 4 cycles of gemcis. We believe maximum response is received by 3 and 4 cycle, and then most of the patient, if they go on our trial, as per the trial, we receive 4 cycles, and even with radiation, they receive 2 cycles, so that the time frame or timeline remains same for treatment for these patients. And then we operate and then complete the remaining 2 cycles.
That sounds more logical, because if you see in advanced gallbladder, it was Dr. Doval's paper on gem-site cisplatin, which was considered the standard of care for advanced gallbladder cancer. So that's absolutely fine. Yeah, please.
So one of the problems is getting a tissue diagnosis always.
Yes.
So have you managed to convince your colleagues to do it without so we keep hearing the radiation guys talk about benign disease, they want to give radiation, but never in a suspected. So in Cochin, we did manage to get our medical oncologists interested if our tumor markers were very high and the very typical, and we had to arm twist them each time in the tumor board, but they did do it sometimes. So what is your protocol in every single case get tissue?
We get tissue diagnosis in every single case if we have to do anything other than surgery. So if it's an upfront surgery, we will do simple chole frozen section and then proceed. But if we have to give neoadjuvant chemo or chemoradiation or chemotherapy per se, we always get a tissue diagnosis. We will not give without a tissue diagnosis, because we have seen almost 50% of patients would probably, which even say for example xanthos, they mimic gallbladder cancer like anything. Even the liver infiltration looks like a malignancy. So 50% may just be benign. So we do not give chemotherapy or radiation without tissue diagnosis.
So if the tissue shows xantho or something, I'm okay with that. What if it is negative for both? What is your protocol for those patients which are
so
clinically?
Then, if it is negative, then we'll probably do a staging laparoscopy and try to achieve a tissue. We will not give chemo or radiation without a tissue diagnosis.
Enjoyed your
Excellent talk, sir, as always. Sir, my question is, do you recommend diagnostic laparoscopy and staging of aortic valve before starting of neoadjuvant chemotherapy in bulky node in the hepatorenal ligament or T3, T4 tumors?
So ideally, staging laparoscopy should be done. That is the recommendation. But a lot of time we have OT time constraint also, but if you definitely have a bulky nodal disease, PET scan locally advanced, you can see periportal big nodes, you have a tissue diagnosis, and there is no other disease, we can start neoadjuvant. But in trial setting, in what trial we are running, staging laparoscopy is a part of trial. All patients undergo staging laparoscopy.
Rashesh.
Sir, enjoyed your talk. Thank you, sir. My question is specifically regarding the myriad manifestations of gallbladder cancer. You have the hilar type of infiltration, you have the parenchymal type, and it seems that the definite answers as far as neoadjuvant therapy in locally advanced CAGB are not available as yet. So do you say that this is a presentation, or this is a mass, as a presentation wherein neoadjuvant therapy won't be effective and I will straight away go for surgery? Parenchymal vis-a-vis hilar, or are there some clinical setting where you would in a locally advanced CAGB still offer surgery as a first choice?
So I am not ruling out surgery for locally advanced gallbladder cancer. Selected cases, yes, surgery where especially you have a doubt about diagnosis. We have had 2 cases, Dr. Shivendra operates much more locally advanced than we do, where we thought it is gallbladder cancer, type 1 block atrophy, little bit of atrophy of that side of liver, probably arterial involvement, but we were not getting tissue diagnosis. So we could not start neoadjuvant chemotherapy, thought probably, and the patient, so all these cases which infiltrate liver, you should always realize if you are doing a right hepatectomy, it invariably ends up in a right extended, and most of the time you may not have adequate FLR for left-sided. And to initiate with a diagnosis measures to improve FLR, you are just wasting time in terms of disease progression. So we did that, and actually it turned out to be a xantho type of thing which was obstructing the bile duct system. So there will always be a place where when you have doubt about the diagnosis and surgery per se, or neoadjuvant chemotherapy, you can definitely go ahead and operate, provided the surgical morbidity is less.
Amit, morning. Amit Kumar from Command Hospital, Pune. One comment and a question. So I'll come to the question first. In the patients who underwent chemoradiotherapy, so what was the experience with the dissection part, especially the hepatoduodenal ligament? Yeah, that's one thing. I'll come to the comment a little later.
So it's very difficult.
Yeah.
So that's why initially when we were giving radiation, we realized the whole thing just plasters.
Yes.
It is very difficult to really, so unless you have really good expert surgeon who is well versed with the anatomy and surgery in that region. That's why initially we had a lot of complication. We had a high biliary rate, but then we modified radiation. They cut down on the dose, more technology advanced. So now we are able to do it. But having said that, still, if you have a nodal disease which is engulfing the pota, so radiation post CT-RT, that whole thing just shows huge desmoplastic rejection, and surgery is very difficult. If we are giving radiation for liver infiltration, it is better actually.
So that was our experience too. We had a study done at AIMS 2011 to 14. We gave only 35 grays. We had a concurrent arm, we had a sequential arm, but the hepatodural ligament was very, very difficult. So from the same study, I come to the second thing is comment is that we did a diagnostic laparoscopy for every patient who was enrolled into the trial or the protocol, and we had a 21% pickup rate in these patients. So I think all these patients that you subject them to a neoadjuvant should undergo a diagnostic laparoscopy before we shoot.
100%. So that is our protocol in trial also, and hopefully if we complete, we'll publish that data also about staging laparoscopy.
Dr. Anil.
Yeah.
Yes.
Yes. Incidental gallbladder cancer should be called only when it is a surprise, histopathological surprise. But here I see in your slides probably, and also in comment, whatever missed gallbladder cancer which should have been diagnosed preoperatively, intraoperatively, are labeled as incidental, including comment here. But my another question is here, before you it was mentioned that earlier cholecystectomy doesn't, whatever way, doesn't affect the second definitive surgery. How it can happen? Because I know the gallbladder has been removed in pieces. I know the gallbladder has been, bile has been leaked. So giving this message here that whatever surgery has been done, one can go ahead and do R0 resection. I have my reservation on that comment. Please.
So incidental gallbladder cancer, I agree, it's a surprise histopathological diagnosis. But we have seen not even incidental, a patient presenting with a small gallbladder polyp and with metastasis, with extensive metastasis also. So it depends on the metastatic potential of the patient, one thing. So message I wanted to give you that a lot of patients present with a lap cholecystectomy done, gallbladder removed in bag, doing everything proper, and surprise diagnosis, which is truly incidental. And if they present to you after say 4 to 6 weeks, you do a PET scan or a CT scan, you find the node which has come up, which is lighting up, or something in the gallbladder fossa in the operative side which is lighting up. You can do FNAC, prove that it is probably positive. So my take on that is only two. One thing, that the disease has come back too fast. So it has already gone to node within a span of 4 to 6 weeks, or it has come back locally. So it is inherently aggressive tumor, and that's why it will qualify to be in a high risk gallbladder group. So because its metastatic potential is high, and other way around, so if it was not a surprise diagnosis, still a lap chole is done and you see a disease in the gallbladder fossa. So either it was not incidental per se, and the surgeon has cut through the tumor, a T3 type of a tumor, left some disease behind. So that would again qualify it to be locally advanced, and that's why they should be treated as high risk gallbladder cancer.
Thank you, Dr. Mahesh. I think with that we close this intensive session. I thank all the speakers and my co-chairs and the audience.